Good afternoon, everyone. I'm Dr. Fadi Nahlawi. I'm a surgical oncologist in Zuleika Hospitals. Uh, my presentation today is about the principles of surgical oncology. I'm going to talk about the most important principles of oncology and the treatment and the diagnosis of the tumors, benign and especially cancers, malignant tumor, and we'll focus on the most important principles and points of the uh, surgical treatment of the tumors and cancer. First of all, let us review quickly the most common definitions in oncology. Uh, as you know, the tumors is abnormal new growth of tissue that have no physiological function and arises from uncontrolled, usually rapid cellular proliferations. We have two types of tumors, could be benign or malignant, depends of the potential to invade or spread through the other part or other tissue out of the primary source or the primary organs. We have pathologically or depends of the characters in the histopathology many types. If the tumors arises from the epithelium, we call it epithelial tumors, which could be if it, benign and called that this in this situation adenoma, or could be malignant and which is called carcinoma. The examples for the epithelial tumors, breast tumors, the gastrointestinal tumor, lung or renal tumor. For the malignant epithelial tumors, actually, they have many characters. They are very invasive. They have the ability to invade the surrounding tissue and the lymphatic tissue with vascular also structure. For example, the epithelial tumors have the ability to metastasize to the lymph node and or the other organs. For example, the ovarian cancer, they have the ability to give metastasis to the intra or abdomen or seeds or metastasis to the omentum. In this situation, this metastasis or this invasions is called local invasion. So epithelial tumors, especially the cancer, the carcinoma, they have the ability to metastasize number one to the lymph nodes around and the other tissue direct invasion, and later on in the late stages it will go by the blood and cause distant metastasis. While if we go to the second type of the tumors, which arises from the connective tissue, which is called sarcoma, for example, the most common example, if it's malignant, or just gastrointestinal stromal tumors, this is the other example. For malignant connective tissue, if it's benign, we have many examples like fibroma, lipoma. For the connective tissue malignancy or sarcomas, actually, they this, spread by the hematogenous spread commonly, and we have here distant metastasis very common in this situation, while we will not see lymph nodes metastasis in this situation. And this is why when we do surgical resection for sarcomas, we are not doing lymph node mapping or dissection to the lymph node around. While when we go to do surgery for carcinoma, whatever from the breast, from the colon, from the stomach, it's very important part to remove a lymph node and or to make sure that lymph node to take sample that lymph node is not metastasis. We'll see this in the coming slides about the staging surgery. So lymph node mapping or dissection is very important part in the epithelial tumor. The third part of tumor is hematological tumor, like lymphoma or leukemia. Actually, these types of tumors are systematic tumors, and here there is no rule actually for surgery unless maybe we can do some types of surgery just for diagnostic or staging, but no rule for surgery as a primary treatment for this type of tumors. About the treatment types of the oncology. When I say oncology, I mean that the treatment of the cancer actually, and the all slides in our presentation focus about the treatment of malignant oncology because we know that the benign tumor, most of them, the main treatment for the benign tumor is only surgery. We will not use chemotherapy, we will not use any types of treatment. So, what the types of treatments we have in the malignant tumor? First of all, before talking about the treatment types, I want just to focus about a very important point. Actually, cancer treatment, it is not one single model of therapy. It is multimodality therapy. Please always remember this sentence. It's multimodality therapy. What that mean? That mean it is not only one type of treatment. Most of malignancy, actually, we use many types of treatment. We'll see now what type of treatment. And before start to any type of treatment, actually, the decision of the treatment, of the consensus of treatment, it should be discussed in something we call multidisciplinary team, MDT, or tumor board meeting. Nowadays, in all worldwide oncology center, actually, we have something we call this multidisciplinary team. The surgeon sit with along with the medical oncologist, the other specialty, pathological, the radiologist, the all other types of specialty will sit together and we will discuss the best and the proper type of treatment, and we put the treatment depends of the case, the type of cancer, the stage of the cancer, and patient situation. So before start any type of treatment, case has to be discussed in this MDT, then we can start with treatment. We know we have many types of treatments for the cancer. We'll start one by one. The first type and the most common type treatment for the cancer is a surgery. And actually, there is one famous sentence that 70% of cancer, you have to shake hands with the surgeon somehow. What that mean? Most of cases, actually, surgery is a main part of the treatment. In some cases, in some situation, maybe no rule for surgery as a curative treatment, as we will see later, but maybe surgery has a rule to put the diagnosis, maybe for biopsy, maybe as a palliative treatment. Very less or few, sorry, maybe few tumors actually no rule for surgery. One example is the hematological tumors like leukemia and lymphoma. The second type of treatment is a chemotherapy. Chemotherapy, as most of you know, that it's a toxic medication, is used to kill cancer cells by interfering with all rapidly dividing cells. Simply, it is drugs used to kill cancer cells. And as you know, chemotherapy actually still had a lot of side effects and a lot of complications. And even with the new generation of chemotherapy, we are still we don't have that drugs which only kill the cancer cells and avoid the normal cells. Why? Because still, even with that new generation of chemotherapy, which actually target the cancer cells and try to avoid the normal cells, but still these chemotherapy drugs kill some normal cells, and this is why many chemotherapy drugs have side effects like hair loss or affecting to the our blood cells and cause maybe bone marrow suppression. Uh, Here we have targeted therapy. Actually, targeted therapy, it is not a chemotherapy. It is a drugs, but which used to block the growth of cancer cells by target specific genes and proteins that area involved in the growth. So this type of drugs will not go and kill the cancer. It's not chemical substance to kill the cancer. No, this is type of drugs will go to that one part during the cycle growth and target this the cancer cell. So the side effects of the targeted therapy, it is much less than chemotherapy because these types of therapy target only the cancer cells, they block only the growth of the cancer cells. We have many examples for targeted therapy like trastuzumab in the breast, which called Herceptin, or cetuximab in the colon. If we want to give some example about chemotherapy, maybe I forget to give you some example. We have many examples. I will give you like the Taxotere, like carboplatin, methotrexate, 5-fluorouracil. So we have a lot of chemotherapy drugs. The fourth type of cancer treatments is immunotherapy. Actually, immunotherapy is a known type of therapy, not used only for cancer. Sometimes we use immunotherapy for another diseases. So, as you see here, immunotherapy in general, it's a therapy can activate or suppress the immune system. In the cancer treatment, actually, the immunotherapy is activating the immune systems, while in the other type of disease, like Crohn's disease or like another type of immune diseases, we use this type of therapy to suppress the immune system. Here, actually, we use this therapy to use some techniques in order to make the immune systems be able to identify the cancer by some way and to fight the cancer itself. And we have here many abilities for the immunotherapy. We can give vaccine, we can give type of viruses inside the body. We can give directly antibodies against this cancer. So we activate the immune system in order to identify the cancer and fight against the cancers. Number five, we have hormonal therapy. I think it is a famous type of therapy we use in many cancers and breast cancer, tamoxifen. Actually, this is a famous example. Here, actually, we use some type of treatment or medicines as an external administration for a specific hormone which affect in somehow the growth of the uh, cancers and cancer cells, and when we give this type of therapy, so it will make or affect the cancer cells death. The last model of therapy used in cancer is radiation therapy. Here we use the ionizing radiation to control or to kill malignant cells, and we have here either external beam radiation therapy or brachytherapy, in which we use sealed source of radiotherapy. And the example here, the brachytherapy, when we use to treat the cervical cancer and we put the seeds inside the vagina, while external beam radiation therapy, we give the radiation by out source, radiation similar to the X-ray, and we give to the targeted area like pelvic or neck or chest or mediastinum. So now, after we knew how what the types of treatments, we review that we have surgery, we chemotherapy, radiation therapy, hormonal therapy, targeted therapy, and immunotherapy. So why we give this treatment, what the purpose of to give this treatment? Actually, here we have four type of the treatment purpose. What that mean in a simple sentence? Some types of some types of treatment we give for a cure as a definitive treatment. That means it will be the main treatment for this cancer. For example, when we have solid malignancy like breast cancer or colon cancer, the main treatment here is a surgery. Another example, sometimes we give chemotherapy as a main treatment for leukemia or lymphoma, it's hematologic treatment. Sometimes we have chemoradiation, the protocol for anal cancer. So we call this a definitive treatment. After finish from the definitive treatment, sometimes we want to give some supportive treatment after the primary treatment. So we call it adjuvant treatment. The most common example, like a chemotherapy after surgery for many solid malignancy like breast, colorectal, or stomach or sarcoma. Sometimes we give radiation therapy as adjuvant treatment after the main treatment after surgery for sarcoma. Sometimes we give radiation therapy after finished chemotherapy for lymphoma. So we call this adjuvant treatment. When we give the treatment before the main treatment, it will call neoadjuvant treatment. That means we'll start with some types of treatment like chemotherapy, like radiation therapy, but we will start as not a definitive treatment, but just to prepare the patient or to prepare the cancer or to achieve some shrinking in size or to help the main treatment to give more good results, so called the neoadjuvant treatment. The examples here, chemotherapy, sometimes we give before the surgery. For the breast cancer, we give radiation therapy before the surgery for rectal cancer. So it is neoadjuvant treatment. We will start with this type of treatment, but not as definitive surgery. And the last here we give sometimes the treatment as a maintenance, just we keep the results which we reach after finish all type of treatment, after do the surgery or after doing the definitive treatment, after we give the adjuvant treatment. So patient now get results, get cure to the treatment. We give in some types of surgery some long-term treatment like a chemotherapy or targeted therapy to maintain the results. We see we use this type of treatment most commonly in metastatic cancer, and the most common type here it is metastatic colon cancer. So now we will go and focus about the most important principles and steps we do during the surgical treatment in malignancy, and which we call surgical oncology. Uh, so, who is surgical oncologist, and why this branch of surgery who deal with the cancers they put in separate uh, definitions? Actually, according to the Society of Surgical Oncology, a surgical oncologist is not only a qualified surgeon who know how to do the procedures, but the surgeons has to have minimal knowledge and in multidisciplinary approach in order to know how to deal with the prevention, with the diagnosis, and the other modality of the treatment, and he has to have some experience in doing researches and reading the researches, because most of the guidelines or the treatment plans of the oncology and cancer always changes every couple maybe of months, depends of the results and long-term researches. So, in the other way, what are the principles and responsibility of surgical oncologists? As I mentioned before, we have 5 points we have to focus on. Number four is a surgical procedures or the type of surgery in the cancer, but it is not alone. It's not our only responsibility how to deal or how to do this procedure. We have to, number one, have enough knowledge about the other treatment modality which we uh, mentioned before, which is called multidisciplinary team. We have to know how to screen cancer among the peoples, how to diagnose the cancer, and at the end, how to follow up cancer patient after finish the treatment. We will explain each point one by one. And I will review again. It is very important point about the multidisciplinary team or tumor board meeting. I told you before, and I will repeat again. Each patient has to discuss before start any type of treatment. This treatment plan is supposed to put together with the other specialty, so it's called multi-modality therapy we have for the cancer. It is not a unique plan or it is not one doctor decision. This is very important, and each case has to be discussed in this meeting with all specialty who should have minimal knowledge for the other modality of treatment. For example, I'm a surgeon. I have to know the types of chemotherapy and radiation therapy. I have to know all and to have some information about these other types of treatment for cancer. And actually, when we put this treatment plan, actually we put according to the, as I said before, to the stage of cancer, to the type of cancer, and to the patient situations. And we following some international guidelines. The most common guidelines we follow. It's called NCCN guidelines, the National Comprehensive Cancer Network. Actually, this is the most important, or it's the most famous guideline. Is our Quran, let us say, for us as oncologists. Uh, these guidelines are updated every 3 months, and they are changing depends of the results of the researchers. Number two of the responsibility and the principles is about the screening. You know, all the screening is a strategy to detect potential health disorders in people who don't have any symptoms. Screening can be for the cardiovascular diseases, can be for some other diseases, and the can be for the cancer. So, strategy to detect the cancer or to potential early stage cancer. We have two types of screening tools. We have non-invasive tools and we have invasive tools. The non-invasive tools, actually, this is type of investigation or tools, maybe laboratory or imaging, which we don't use that aggressive procedures. So could be by simple lab test or by imaging. The examples for the non-invasive tools like mammogram, which we use to detect early breast cancer, oral examination to detect the intraocular lesions, stool-based tests like fecal occult blood test or other type of test to detect the colorectal cancer. We have the PSA to detect the prostate cancer, and as you know, all of you, pap smear and HPV to detect early stage cervical cancer. Invasive tools I mentioned before. So we use here some types of procedure, actually, not only investigation to detect the cancer. So maybe more we use the anesthesia to do this procedure. The examples for invasive tools is colonoscopy or gastroscopy to detect uh, precancerous lesions like polyps or early cancer, small cancers in the colorectal cancer. Hysteroscopy also, it's type of procedure which done under general anesthesia to examine the endometrium and to detect the early lesions for the endometrium cancer or cervical cancer. Number three of the principles or responsibility, it is diagnosis. How to diagnose patient with cancer. Uh, Actually, diagnosis, if we want to uh, uh, explain what the type, how we put the diagnosis. We have three models of cancer diagnosis. Number one, by clinical examination. Number two, by imaging. Number three, by biopsy. So, clinical examination is the first and the most important step in which we can suspect that patients has lesion could be a cancer. Then, by some imaging, which is the difference between cancer to cancer, and we confirm the diagnosis by doing the biopsy. The most common example for these three diagnostic tools, which we call the triple assessment for breast cancer. You know, it is nowadays when I ask or someone asks you how we diagnose the breast cancer, you should answer by triple assessment of breast cancer. That means by collecting data from the clinical examination and from imaging, and then later on from the biopsy, we put the diagnosis. Yes, we know that the most important part to put the diagnosis by biopsy, but uh, even biopsy actually we have something we call false positive results. So even we have positive results of biopsy, which refer that patient has a cancer, but if I'm a doctor, I saw that the clinically patient doesn't have this clinically suspected to be a cancer, or imaging doesn't reveal that patient has this type of cancer, I will not consider it. Maybe I would repeat the biopsy. So the triple assessment for a cancer, and especially for a breast cancer, which it is very important. And all studies I mentioned that the diagnostic accuracy for the triple test score or a triple assessment, it's called triple test score TTS, is nearly 100%. We have some principles when we use the diagnosis. What that means? Uh, Actually, when we ask for some investigation, we have to put in our mind that uh, there are some characters of this investigation. Number one, we have to know the tumor biology, how the tumor is, what the type of tumor, how it's spread. Is possible or that cancer, when we do the biopsy, for example, it will seed outside the primary tumor, like testicular cancer or kidney or ovary. Yes, sometimes of tumor, like three tumors, actually they have high risk to spread outside the primary tumor when we do the needle biopsy. So in these three cases, we have to avoid this needle biopsy, and we have to go for another type of biopsy like excision biopsy. We'll talk about this. I will focus in one point. The biopsy is very safe procedure, and not all type of biopsy it's caused like the spread. Only needle biopsy in some types of cancer like testicular or kidney or ovarian cancer actually possibility to spread outside the primary tumor is very high. So that's why when we have high suspected mass in the testis or in the kidney, with imaging CT scan, for example, which tell us that it's high suspected to be a malignant, we have to go directly for excision biopsy and to remove this organ like a testis or kidney or ovary. So we have to avoid needle biopsy in these types of surgery. Number two, we have to know exactly when we have to ask for this investigation, which investigation we have to request first. When we have suspected mass, for example, in the breast, shall we go directly to do the biopsy, or we have to start with the simple investigation like mammogram or ultrasound or MRI, whatever, then we go for biopsy. It's very important. Why? Because sometimes when we start with biopsy, then we do the mammogram will not obtain clear picture, or this biopsy or needle biopsy could give us some changing in the character of the mass, which we need to know exactly. So in this type of cancers or malignancy, we have to start with the investigation, then we go to for the biopsy. Number three, before doing any type of investigation, we have to ask ourselves, shall this diagnostic tool change the treatment plan or no? If it will not change, so what is the benefit to do it? I will give you an example. When we have head of pancreas mass, and in patients had the uh, all signs of head of the pancreas cancer, like jaundice, loss of weight, and in CT scan it tells us that the mass it's high suspected to be a malignancy. So shall we go for biopsy, for example, which is little bit dangerous here in this area, and it is difficult to obtain from here or no, and it will change the treatment plan, because we know that any head of pancreas mass, even it's benign or malignancy, the treatment is surgical resection, which called Whipple resection. So it will not change. Even it's benign, we have to go for this type of surgery. So in this scenario, we can skip the biopsy, and we can go directly for the procedure. Another example, when we have, for example, multinodular goiter, which is a very big, which causing an symptomatic pressure signs and symptoms. So the indication here for surgery, whatever the situation, if it's malignant or benign or suspicious, here we have to go for surgery. So I can skip this step, and we can go directly for the surgery. But if it will change really our treatment plan, if it will change that, for example, thyroidectomy, I don't know if it is malignant. I have to go for total thyroidectomy, but the nodule it is only in one side and it's benign. I have to go for only lobectomy. The biopsy is very important, and we have to go. So we have to ask ourselves before doing any type of investigation. Really, it will help me to put the treatment plan or no? And at last, actually, we have to know the available diagnostic tool for each part of the body. So I should not go for I should not request all type of investigation if I don't know really if it will help me in this type of surgery, or this type of cancer or no. For example, I will give you some examples. MRI is very, very sensitive for soft tissue tumor and cancer. So if I suspect tumor or cancer in the soft tissue, so better to request the MRI, not CT scan. Biopsy also here very sensitive for tumor soft tissue. For example, if I have some thyroid nodules, actually ultrasound is very sensitive, and we have to start with this ultrasound as a simple way for diagnosis, which is sometimes is more sensitive than CT scan. And we have to go later on if it's indicated for fine needle aspiration, not a true cut biopsy, because fine needle is more simple, and it will give us very good information. Another example here, for example, PET scan. PET scan, it's a type of scan used to stage the cancer and to put the diagnosis, which give picture like hyperactive area or shining area in the scan. But similar to other type of investigation, actually the PET scan is not sensitive for all type of cancer, and sometimes it's low sensitivity to the PET scan. Uh, we'll stay in the diagnostic tools, but I will talk a little bit about the biopsy. We talk about the biopsy, what type of biopsy we have. Actually, number one, we have the needle biopsy, we have the excision biopsy, and incisional biopsy. About the needle biopsy that mean we take a sample from the mass by a needle. This needle could be by a fine needle, uh, which called fine needle aspiration, FNA, by simple needle, could be by a thick needle, which we call here core needle biopsy. The difference between the fine needle aspiration and the core needle biopsy. Fine needle aspiration actually it is very simple procedure. It can be done without local anesthesia, but here actually we only collect cells from the lesions, so it will be cytology only. It, this fine needle aspiration can tell us if it's the tumor or the mass is malignant or benign. But in the same situation, cannot tell us more details about the cancer, while the core needle biopsy actually it will collect a tissue. This core needle biopsy also a simple procedure, can be done under local anesthesia, uh, but we can collect the tissue actually. So we can do more tests if we want about the specimen. We can do more histopathologic studies in order to give more information. Vacuum biopsy, it's type of core needle biopsy, but we use specific machine in order to help us to get the specimen. And we used mainly in breast, for example, mammogram or ultrasound guidance, and we use specifically for the small calcifications to get this tissue biopsy. The incisional and the excisional biopsy, that mean we use the surgical removal to the tissue. Either we remove part of the tissue in order to get the specimen, which is called incisional biopsy, or we remove the whole entire mass or lesions, so it's called excisional biopsy. When we use the excisional biopsy or incisional biopsy, we send to the histopathology, and to here we can keep this specimen either by paraffin for uh, permanent biopsy, or we have something we called frozen section, which is a technique to freeze the biopsy, and we use the specifically intraoperative in order to get quick results within 20 minutes. Similar to the principles of imaging, we have some principles of biopsy. For example, we have to avoid needle biopsy in high risk seeding tumor, as mentioned before in the tester or kidney or ovary. So in this situation, we have to go for excisional biopsy. We have to avoid the biopsy in some areas in the body when it's high risk size. For example, through cut biopsy in the neck. So here we will go for FNA, fine needle aspiration. Similarly, for the head of the pancreas, sometimes it is high risk because it is deep organ, and the possibility to be injury to the some structure is very high, so we have to avoid here, and we have to go for cytology and FNA. And we have to know exactly what is the treatment plan, surgical plan, when we go for the biopsy, because when we go for the surgery, we have to do the biopsy in the size at the side uh, area of the surgery. When we want to take biopsy from the breast mass, for example, we have to take the entire area of the needle should be in the area which we planning to remove in the future if surgery is indicated. Now we will go for the surgical procedure in the oncology of the surgery itself, the type of surgery we do to treat the cancer. Actually, we have 6 types of surgery we do for the cancer. We can do the surgery as a curative procedure, definitive procedure. We can do surgery as for the palliative, and reduce the symptoms, to control the symptoms. We have something we call cytoreduction surgery. We have sometimes we do surgery for staging. We can do surgery as a prophylactic surgery, or at the end for reconstruction or reconstructive surgery. The definitive surgery, as mentioned before, the aim is to remove the whole entire tumor with some healthy tissue around the mass. So we have to remove all the mass as a definitive or a curative surgery. Here, actually, we have some points in a curative surgery. We have to talk about this. When we do curative surgery, as mentioned before, we have to make sure that we didn't uh, leave any part of the tumor. When we say our zero curative surgery, this is the curative surgery. That means we didn't leave any type of residual mass or cancer macroscopically or microscopically. When we are not sure that we remove the mass, the old cancer cells, or we kept some microscopically maybe lesions. Sometimes, for example, the mass is adhered to the vessels, so not be able to remove negative margin around. So we're shaving the mass, so it's called R1. That means still microscopically the some residual in the area. While when we left big area macroscopically, a residual tumor is called R2 resection. When we do curative procedure, actually, we have to do for non-metastatic cancer in most cases. We have some exceptions, we'll explain later, that even we have some metastasis, we can get curative surgery when you remove the primary tumor along with the metastasis. But in most cases, in most solid malignancy, in order to get the cure, we have to make sure that the cancer it's not metastatic and there's no distant metastatic or the mass it's resectable. So in order to do the curative procedure, in most cases should the cancer should be not non-metastatic. And in order to reach the cure, we have, as we mentioned before, we have to remove some healthy tissue around the mass, which called margins, healthy margins. And we have to get adequate margins to remove the mass. Actually, this margins be difference between cancer to cancer and depends of the type of the cancer. For example, in the breast cancer, nowadays the accepted margins just to remove the cancer with simple one layer of the healthy tissue around. And this we call no ink on tumor. What the meaning of no ink in tumor? That after removing the cancer, we just inking the all aspects of the resected specimen, and in the histopathology will examine under the microscope if that ink or area is free, even it's one layer of the uh, healthy tissue is enough. While in the other type of cancer like melanoma, we have to get 1 to 2 centimeter of healthy tissue. Similarly, for the sarcoma, actually, we have to get at least 1 to 2 centimeter in order to get good results and cure resection. One more thing, actually, during the resection, we have to be careful not to make spillage, or we have to reduce the manipulation during the resection of the cancer, which is called in block resection. Some other points, high arterial ligation, it is necessary in order to remove the whole cancer and the whole specimen. For example, the colon cancer, when we remove the do colectomy, we have to ligate all the main vessels at the origins in order to make sure that we remove the cancer with all possibility seeds or metastasis lymph node around. Curative surgery can be done under open procedures or laparoscopic procedure, and now laparoscopic is the standard for many surgery, and laparoscopic procedure now it's not contraindication to get curative procedures, because laparoscopic surgery is very helpful, and we have a lot of advantage when we do the laparoscopic procedures compared with the open surgery. We have something, as mentioned before, metastectomy. Metastectomy actually sometimes could be a curative procedure. We mentioned before that when we want to go for curative procedure, when we want to remove the primary tumor, the first things we have to make sure that the lesion which we remove, it is non-metastatic. But we have some exceptions like colorectal cancer and neuroendocrine cancer. In this type of cancer, even we have metastasis, for example, in the liver or in the lung, if we remove the primary tumor, then we remove the metastasis along with the primary tumor, so we can get a cure here. While in the other type of cancer, we know once it's metastatic, we have some metastasis in the other organs, so that means it's end stage and no rule for surgery as a curative surgery. For example, head of pancreas cancer or stomach cancer, when we have liver metastasis from this type of cancer, so we know that it's end stage and patient will not get cure from the surgery, so we will give other types of surgery as a treatment like chemotherapy and maybe radiation therapy. While in colorectal cancer and neuroendocrine cancer, actually, we can get the cure after removal of the primary tumor and the metastasis. But we have some specific rules in this situation. Number one, that the primary tumor should be controlled. That when we remove the metastatic, we have to make sure that we'll be able to remove the primary tumor. And we have to, when we do this, we can do the metastectomy along with the same setting of the when we remove the primary tumor or in the other setting. So number one, we have to make sure that the primary tumor is controlled or can be controlled. Number two, we may have to make sure that the metastasis is single or localized or resectable. This is very important point. What that means, if we have, for example, even from colorectal cancer, we have metastasis in the liver, but it is multiple metastasis in right and left lobe. So here the metastasis, we cannot remove all metastasis because it will affect the liver function, for example. While if it's the metastasis in one side, so here we can do metastectomy or segmentectomy, or we can remove the right lobe or the left lobes. So we have to make sure that these metastases are resectable and we remove the all metastases in order to get the cure. And we have to also to know if patients has any other morbid comorbidity, maybe affecting the health status of the patients. If patient cannot tolerate these types of surgery, so will not go for this metastectomy. Also, we know that in some type of metastasis we can remove other, but while we have a lot of types we cannot remove. For example, liver, lung metastasis, uh, brain metastasis, in sometimes bone metastasis we can remove. But sometimes if the metastasis it is very bulky, very big, it's adhered to the major vessels, so will not be able to remove it. And similar to the primary tumor removal, when we want to remove the metastasis, we have to get margins free, and we have to make sure that we didn't leave any type of residual tumor. And at the end, actually, we can use many types of treatment, not only surgery, for the metastasis. Actually, we can use, for example, radio frequency or microwave to deal or to burn or to remove all the metastasis. It's accepted in some circumstances if the metastasis is small, unique, can be removed totally by this type of minimally invasive procedure. So I think we spoke about the curative surgery. Number two of the surgery we used in the cancer, it's called palliative or symptoms control procedure. What that means? I told you that we go for surgery to resect or to remove the entire primary tumor. In some cases, if it is metastatic or end stage, actually no rule for curative surgery. For example, when we have multiple metastases in the liver and in the lung, and the primary tumor is breast. Shall we go for mastectomy? The answer is no, because here no rule for mastectomy or as a curative surgery. But here in this situation, we can go for surgery just to reduce or just to control or to relieve the symptoms which can be due to the tumor itself. You know, sometimes in the advanced cancer, patient can develop severe pain. Sometimes in the we can see gastrointestinal obstruction or biliary obstruction due to the cancer. Sometimes the cancer or the primary tumor can make severe hemorrhage, can make poor nutrition. Patient will not be able to eat because of the cancer in the end stage, or sometimes you can cause airway obstruction. For example, when we have bulky big neck tumor, for example. So in this situation, we can go for sometimes some types of surgery just to control these symptoms. The surgery is not necessary to be a resection or to we have to resect the tumor. Sometimes we just do some procedures just to relieve the symptoms. So we have many types of palliative procedures. We can do this procedure with non-surgical procedures nowadays. And when we have this non-surgical procedure available and will be effective, so better to go with less aggressive procedure. I will give you example. When we have obstruction in the biliary tract due to the head of the pancreas tumor, so we can relieve the jaundice by two ways, either by put stent, just put stent by endoscopy, ARCP, or we can do the old way to do cholecystectomy, for example, which is need surgery and laparotomy with under anesthesia. So if we have this gastroenterologist and he can do ARCP, for sure we have to go for the less invasive procedure and we have to go for stent. Another example, when we have bleeding, for example, from the tumor, like a kidney tumor or breast tumor, and it causes severe bleeding. So yes, we can go for debulking, for surgery, just to remove the tumor in order to control the bleeding. But if we have intervention radiologist who can do embolization to the area or to the blood supply of the tumor or to the artery, so of course we have to go with this way. So the point here, yes, we have palliative uh, procedure, but it should be a second choice if we have non-aggressive or non-surgical procedure available. Number three of surgical procedure to treat the cancer after the curative treatment, after the palliative treatment, we have something we call debulking or cytoreductive surgery. Actually, this debulking or cytoreductive surgery, it is in the middle between the curative surgery and the palliative surgery. That means in some types of cancer, it's accepted to not to remove all cancer cells. Uh, it's accepted to debulk the tumor and to remove the maximum volume if tumor, if it's possible. Then we can continue the curative treatment by another way of treatment. This type of surgery is called debulking or cytoreductive surgery. So the main purpose here when we do this, it is for curative, yes, but if we can remove the tumor, it's okay. But if we cannot, if we can reduce the number of tumor cells or to remove the maximum volume of the tumor, is accepted. But this type of surgery, it's only accepted in some cancer, like ovarian cancer, or like in some types of metastatic intra-abdominal metastatic peritoneal metastatic from colon cancer. But the most common example here, the ovarian cancer. Sometimes if ovarian cancer, I mentioned before, give metastasis intra-abdomen to the peritoneum or to the omentum. So we see a lot of seeds or metastasis inside the abdomen. Here we can go for laparotomy and do debulking to the tumor and all the metastasis, to the ovaries, to the uterus, do hysterectomy and remove the all lymph node, pelvic lymph node, upper aortic lymph node, and all peritoneal seeds and omentum, which is called metastectomy. So if we could reach our zero, it is very good. If we couldn't, so R1, it's accepted, which is called cytoreductive surgery. Number four of the types of surgery we do in the cancer, it's called surgery for staging cancer. That means we just do the surgery for purpose of staging, not for a cure, not for a palliative, just to know the staging of the surgery. You know that the staging is a way to classify patients according to the spread of cancer. You know, cancer, we have many level of staging. Cancer can be in the early stage if the cancer only in the primary tumor. Cancer can be invade to the surrounding tissue on the lymph node, so it's called locally advanced. And if we have distant metastasis, so we are in the stage 4 or end stage. Let me talk about the staging. The most common classification of staging we call TNM. T to know the size of tumor and the number of lymph node, and M for distant metastasis. And we have two types of TNM staging. Number one is called clinical staging. Clinical staging, that we put the staging of the cancer before start doing any type of treatment by non-surgical tools. That mean by clinical examination or by imaging like CT scan, PET scan, MRI, endoscopic ultrasound, etc. So it's called clinical staging. For example, when we have breast cancer, the breast mass is very big. Patient has clinical lymph node metastasis, no distant metastasis in PET scan, for example, or in MRI. So by this non-surgical tools, we know that this cancer is locally advanced. Second type of staging for the cancer is called actual pathologic cancer. That means we will put the correct staging, but after the surgery, or we use the surgery to put the staging. Here we have type many examples about this type of surgery. For example, in the mastectomy, when we do lymph node dissection or sentinel lymph node, the aim of removing this lymph node not just to clear the lymph node. Yes, we have some benefit when we remove the lymph node in the breast cancer. We have some benefit to remove the cancer cells or to get the cure. But the main aim of when we do lymph node dissection and sentinel lymph node actually is to put the correct uh, pathological staging to know really if the cancer has spread already to the lymph node or no. In this scenario, actually, we have when we are talking about the lymph node dissection, we have minimal numbers of lymph nodes had to be dissected in the breast. In order to put the correct staging, we have to remove at least 10 lymph nodes from the level 1 and 2. In the colon cancer or colorectal cancer, in the specimen, we have to remove at least 12 lymph node, and etc. We have a lot of type of cancer. We remove the lymph node like a melanoma or like endometrial carcinoma or ovarian cancer. Sentinel lymph node, which is the first lymph node which collect the drainage from the primary organ, and we do this concept just to avoid lymph node dissection in early stage cancers. So also it is type when we do the surgery only for staging. Actually, when we do cytoreductive surgery, that when you remove the maximum volume of the tumor, especially in the locally advanced ovarian cancer, also one of the aim of this procedure is to put the staging. Uh, and we have also one famous example, but it is nowadays we are not using this. It's we do some before we were doing the surgery just to put the staging for lymphoma. We took biopsies from several parts of the body above the diaphragm or below the diaphragm just to know which stage is the lymphoma. But nowadays, as I told you, we are not doing this because we are do PET scan before that. So this is the actual pathological staging. So when we read the pathology reports, so they are putting the staging, it is mentioned P, PTNM. While when we said CTNM, that means it's a clinical staging before the receiving any type of treatment. What the benefit of staging? Actually, the staging, maybe someone will ask, why will we go for procedure or surgery to do the staging? Actually, staging is very, very important in the oncology field. It is, as we mentioned, it's classified patient according to the tumor spread and level. Also, it's guide to sell in some situation. It's help us to select the proper adjuvant treatment according to the stage. We have another also benefit like to estimate the prognosis, to evaluate the results after neoadjuvant treatment, or to decide if patient need further investigation or no. The fifth type of uh, procedure, surgical procedure in cancer patients, it's a prophylactic or cancer preventive surgeries. Number one, the prophylactic surgery. It's a procedure done in patients with known to have high risk to develop cancer, or they have some genetic uh, mutations associated with the high risk of cancer. For example, BRCA1 or 2 genetic mutation is associated with high risk to develop breast cancer and ovarian cancer. We do here bilateral prophylactic mastectomy and oophorectomy. Main two red mutations associated with thyroid cancer, medullary thyroid cancer. So we do here total thyroidectomy in early age. Similarly, for patients, they have family history of familiar adenomatous polyps or mutations for the syndrome. So we did prophylactic total colectomy. The other type of surgery is called cancer prevention surgery. That means here we do some type of procedure and we remove some lesions, which is precancerous lesions, and which is if we don't remove or don't treat it, so this type of lesion will be a cancer. The example, when we do polypectomy during the colonoscopy, or when we do endoscopic submucosal dissection for some lesions in the stomach also. This type of procedure is under cancer prevention surgery. Similarly, also leukoplakia, when we remove this leukoplakia for these lesions, for the tongue lesions or intraoral leukoplakia, so we know that leukoplakia associated with high risk of squamous cell carcinoma. So this type of procedure is under this cancer preventive surgery. The last type of surgical procedure in oncology or in cancer is a reconstructive surgery. This type of surgery is known the aim to restore function or normal appearance of organ or tissue after removal. The common example here, the breast reconstruction after doing mastectomy, or reconstruction after removing some organs like a testis or eye or even the skin. Actually, here we can use tissue, two type of reconstructive materials. We can do either by autologous tissue from the same tissue from the patients, or we can prostheses like implants to reconstruct the organ, the removed organ. We can do these procedures either immediately at the same sitting of the resection surgery, so it's called immediate reconstruction, or we can do it late after finish all type of treatment, after finishing surgery or other adjuvant treatment if indicated. So it's called late reconstruction. For the follow-up, which is the last responsibility for the surgeon, we know that the real procedures, we uh, talk about the types of procedure can be done in the cancer, the real surgical procedure, the other responsibility, the screening, the diagnosis, the multidisciplinary team, and the follow-up. Follow-up is very important after finish the treatment. either by surgery or other type of treatment, we have to keep patient for follow-up at least for 5 years. Why 5 years? Because the the most common time to develop relapse or recurrence after the treatment is first 5 years, and for sure the first 2 years is the most risky time after finishing the treatment. Anyway, if patients pass these 5 years after treatment, most probably that patient get cured, and the risk to develop any relapse or recurrence is very, very low. In the lectures or in our practical daily work, actually, sometimes we see some patients has recurrent or a relapse after 15 years or after 20 years, but it is not a standard. 5 years, if any relapse or any recurrence, most probably it will happen first 5 years. Anyway, we have some guidelines regarding the time of follow-up or the type of investigation or how to follow these kind of patients. Actually depends of the type of the surgery and depends of the stage of the cancer in patient. So according to the stage and the type of surgery, we give the follow-up program to the patient. Maybe we have to follow him every 3 to 4 months, every 6 months, or maybe we ask to do some regular investigation every visit, or sometimes only clinical examination with some simple investigation. So by ending by the follow-up, so I think I we review the most important responsibilities and the most important principles of the surgical oncology and the oncology in general. Uh, I think now all of you have minimal idea about how to diagnose, how to screen, how to deal with these patients, how to put the proper treatment plan. Next, we will discuss the in practice how to get benefit or to use these principles in our daily practice, how to really use this information to put the proper treatment plan or to put the proper investigation, how to choose the proper diagnostic tools and treatment plan. So I think next we will meet in the interactive presentation. We will discuss some cases, scenarios, just to see between me and you how to put answer these questions and how we'll really use this information in our daily practical work with patients. Thank you very much for listening. See you in the presentation.